Okay, thanks everybody for joining us today for our series of lipid management that we've been doing with the Health Innovation and part of our System Transformation Fund in West Yorkshire. So today is a continuation of a theme of different talks that we've been delivering. And today we're going to be talking about new lipid lowering therapies, practical deep dive. And it's my pleasure and our pleasure to have my colleague, Professor Derek Connolly, who's a consultant cardiologist from Birmingham City and Sandwell Hospitals, with many other responsibilities. He's the Director of Research and Development as well, and he is a colleague and a friend. So without due more introduction, I hand over to Derek. After just sharing with you these few housekeepings, this session will be recorded. Please ask any questions as we go along throughout the chat. There's a chat. And at the end of the session, there will be a brief questionnaire that will be grateful for you to complete, which will be tell us a bit more about what we need to do better and what we've done brilliantly. So I'll stop sharing and I'll let Derek share his slides. And over to you, Derek. Thank you.
Thank you very, very much for the invitation. Let's see if we can get to PowerPoint. And it's really been an incredibly exciting year for cholesterol. For the first thing to say is that for the first time in 7 years, we have cholesterol as part of the GP contract. But secondly, I think we have all of these new options, and there are lots more coming. By the end of this decade, we're going to have 10 drugs to lower LDL cholesterol. But the first one, of course, we've had was bempedoic acid, and I'm going to start with that and try and put this in perspective. To put it into context, 20,000 people in the UK are now on bempedoic acid. We know that it's taking off, and I'm going to go through what we know and based on the trial data. Literally, in the last couple of days, we've had another paper produced. There are almost weekly papers now on bempedoic acid, and we're learning a lot more about it, particularly as we use it. So I'd like you to know about it. It's certainly part of my armamentarium. I've got all the local GPs in Birmingham and the Black Country prescribing it, and it does have its niche. So let's go through things. Just remember that although I'm not being funded at all for this, I have had my research and I've given advisory boards and talks for all of the manufacturers of all of the lipid lowering companies because I've done their trials, and that includes Daiichi, who market this in Europe, but not in North America. Before we start, I always pay homage to Michael Francis Oliver, who was one of my teachers. He was the professor in Edinburgh. He did one of the very first trials. He did a trial with a drug called clofibrate, and we know last year that my friend Paul Ridker did a trial with an even better fibrate, and it didn't work. So not surprisingly, 30-odd years ago, 40-odd years ago, Michael's drug didn't work, and he initially believed, although he'd shown that cholesterol caused heart disease, he initially believed that lowering it didn't work, but he changed his mind. And of course, he changed his mind because of statin therapy. Statins have been around now for nearly 50 years. Endo and his colleagues discovered them in Japan, but it wasn't until it'll be 30 years ago next year that my friend Terry Pedersen he and I teaching a couple of years ago. I was in the audience for this in Anaheim in California when he presented the Fourrier trial using the moderate intensity statin, simvastatin, and he gave it to patients. He only got an LDL cholesterol reduction of 35%, although the starting LDL was nearly 5 in most of the patients. But you all know he showed a reduction in cardiovascular events, and that resulted in a lot of trials over the last 30 years where we've used higher potency statins versus less potent statins. We've used higher doses of those high potency statins. And then for the last 15 years, we've been trialing all of the other drugs we now have in our armamentarium. And as I say, lots more are coming. One thing to say is statins are wonderful, but it is about the dose. This is a really simple study from 20 years ago. We gave everybody 10 milligrams of atorvastatin for 6 weeks. If they could tolerate that, they got 10 or 80. It was blinded. And as you can see, 80 caused a big reduction in cardiovascular events. And that only was with a 23% reduction in LDL cholesterol. But, you know, that tells you when the general practitioners are lowering the atorvastatin from 80 to 10, they're actually doing the patients a disservice. And remember, these drugs are incredibly cheap. What's more, we know that cholesterol is all about exposure. The longer you're exposed to cholesterol and the higher your cholesterol, the more the plaque fills. And the higher the volume of the plaque, the more stretched The surface is like a kiddie's balloon. You blow it up with air. Eventually it pops. This vulnerable plaque with the thin cap will pop. The cholesterol will see the blood, cause a clot, cause a heart attack, cause a stroke. And we know from studies like this, and this is 20 years ago from Steve Nissen and Steve Nichols, that if you gave a high potency statin like rosuvastatin and you get the LDL down low enough that you reduce the volume of the plaque, if a balloon comes down in volume, it's less likely to pop. The cap becomes thicker. Eventually, and all lipid lowering therapies do this, the body encases it in calcium and bone to stop it rupturing. And that's a healing process. But we know we can reverse atherosclerosis. When I was young, it was thought not to be reversible. We know we can now reverse it. And you can see at the bottom there in blue, we've done a plethora of statin trials. There are 4.1 million people in statin trials. But up there at the top, and I've been involved in lots of these trials, we now have the trials of all the other therapies that lower LDL cholesterol. Now, statins are the mainstay of what we do. I take 40 milligrams daily of atorvastatin because my QRIS-3 score was 7.5%, and I thought this was sensible. And it costs £12 a year. Interestingly, I have to get it on 2 monthly prescriptions at £12, well, whatever the prescription charges, and it's £12 a year. So yesterday evening, I was in Parliament arguing that we should make atorvastatin off prescription because £12 a year, we get many, many more people taking it, and it lowers your LDL cholesterol by around 50%. One of the simple projects you can do is get everybody who was on pravastatin, on simvastatin, onto atorvastatin. Atorvastatin, I think, is the preferred drug. But on atorvastatin, you're only going to get about a third of patients to this new QOF target of 1.8, which is, by the way, the old European target. We've moved on. But if you've got a target at 2.6, the very old European target, you get 4 out of 5 people there. Once you lower it to 1.8, remember that number, you only get a third there with high potency statins. So if a blood pressure came from 180 to 165 with 5 milligrams of amlodipine, you wouldn't stop there. You would add in additional therapies, and combination therapies are going to be necessary in most patients with lipid lowering. Now, the other problem we've got is real or perceived statin intolerance. Of the 4.1 million people in statin trials, about 9% couldn't tolerate it, wouldn't tolerate it. We know from trials like Samson, a trial done at the Hammersmith Hospital, that an awful lot of this isn't real intolerance. They gave people with statin intolerance either placebo, nothing, or statin, and on placebo and statin, patients got side effects. When they were taking nothing, they got no side effects. So we know that a lot of statin intolerance isn't real, but the truth is, if people perceive it, they don't take the tablets, then we're in problems. And of course, it doesn't help that the Daily Mail publishes things like this: statins potentially killer complication. Well, this isn't really a killer complication. It's bad journalism. These are over the 30 years. And remember, there are 90 million lipid lowering prescriptions every year in the UK. 55 million, by the way, are atorvastatin. In 30 years, 10 patients had myasthenia gravis that might have been linked to statin usage. None of them died. But of course, this sort of story, and I spoke to the Daily Mail yesterday, this sort of story stops a lot of people taking their statins. But, at the end of the day, if you don't take your statin, won't take your statin, you don't get the benefits. And we know this. And we've shown, and I'll show you data from the Santorini study, that a lot of people don't take the statins. That also in the pandemic, and this is official NHS England slide, you can see there was a big reduction in lipid lowering therapy usage. Well, one thing that is nice, although the numbers are small, is we are seeing more and more primary care doctors giving combinations of therapy. So the message is getting through. But we now have the randomized control trials. We have data from studies like Framingham, where people are followed up as cohorts for many years. And now I'm very proud to say that the UK leads with the UK Biobank. 500,000 people's genetics are in a freezer halfway between Oxford and Cambridge. We can analyze their molecular biology, their DNA, their small nucleotide variations between genes, and we can see what's causing heart disease. And with 50 years of follow-up, we can predict trials, what the outcome would be if we do things like lower blood pressure, like lower cholesterol or Lp(a). What's more, we can go back. We know that cholesterol is all about exposure. It's like pack years. The higher your cholesterol, the longer you're exposed, the more the plaque will form. Similarly, if you lower the cholesterol with a drug, and no matter what the level is and how long it is, you can calculate the benefit. And my friend Kosh Ray has gone back and done this, and all the trials line up. We know it's all about LDL cholesterol reduction. So here on the left, we've got the Fourrier study with Terry Pedersen, lowering LDL from 4.9 to 3.2. On the right is a study called Fourrier, more about that later, that I was heavily involved in, where we lowered the cholesterol from 2.4 to 0.8, and we showed additional benefit. So much so, in the last 6 weeks, the American Heart Association have said there is no too low in LDL cholesterol. That is an official statement of the AHA. So we know that taking the LDL is lower. And here is the statement yourself. Please show this slide to all of your patients, particularly people who stop statins because the cholesterol is too low, or any lipid lowering therapy. There is no lower limit. The lower you take it, the benefit. I'm going to show you data. So here's an audit we did. This is a study called Santorini, the first study looking all around Europe at what people are doing. And one of the interesting things about this is that 1 in 5 people are on nothing. These are people that deserve lipid lowering therapy, particularly the high risk ones, are on nothing. And yet, you can also see only about a quarter overall in Europe are on combinations of therapy. Now, unfortunately, in the UK, we're worst of all. We come out at 76% of the population are on monotherapy, whereas places like Portugal, and I was in Portugal lecturing at the weekend, they've got half their patients on combination therapy. We need to use much more combination therapy, and we need to do something for those patients who are not on anything. So, is bempedoic acid the answer? So we all know that statins block HMG-CoA reductase in the liver and the muscles, and in doing so, it stops cholesterol synthesis. Bempedoic acid, which is a prodrug, works in the liver and only in the liver because it needs conversion, and that only happens in the liver. And it blocks an enzyme called ACL, which is a couple of points above HMG-CoA reductase. Now, bempedoic acid as a monotherapy only lowers your cholesterol by about 20%. But it does it without the muscle side effects, which is quite important. This has been shown in lots of clinical trials. This is the Clear Harmony trial. Fourrier was the international lead of this. Again, about a 20% reduction in LDL cholesterol. What is the dose of bempedoic acid? Anyone that has ever played darts will know the answer to this. 3 darts in the treble 20 is 180. But the secret with this drug is to give it with ezetimibe, because if you give it with ezetimibe, you get a 38% reduction in LDL, which, by the way, is bigger than the 35% reduction in LDL that Terry Pedersen showed in Fourrier with simvastatin, with no statin, with a single daily combination tablet. Now, it's absolutely recommended in Scotland. This is the SMC. And importantly, in England, it's absolutely recommended. And you can read it. It says where statins are contraindicated or not tolerated, whereas ezetimibe doesn't alone control the LDL. And to be fair, if you know ezetimibe, which is a wonderful drug, as a monotherapy, it's only £20 per year. We should use a lot more of it. We are using a lot more of it, such that the companies are running out of it a bit because we're using more of it. We need to use more and more of it. But the bottom line is that will lower your cholesterol by 20%. To get 38%, you have to give the combination tablet with bempedoic acid. And it's absolutely prescribable in Birmingham and the Black Country. And most of those prescriptions that we've had in the UK have been in Birmingham and North London because of Cautionary. But increasingly, we're seeing islands of it opening up around the UK. Now, importantly, this is a paper we had in the European Heart Journal last year. You can see for very high-risk patients, that's anyone who's had a heart attack, stroke, anyone with a Q-RIS-3 above 10%, we think that you shouldn't just start with a statin. You should start with a statin and ezetimibe, because you're then getting 65% LDL cholesterol reduction. And if you don't get it, this is the European guidance, not the British guidance, then you add in PCSK9 targeted therapy more later, or bempedoic acid. You get about another 10% reduction in LDL if you give bempedoic acid on top of a high potency statin. But look here, extremely high risk patients, we think you should go in. That's the ones with the frequent flyers, multiple heart attacks, disease in multiple areas. We think you should go in with multiple therapies relatively quickly. Now, with bempedoic acid, for those of you who know that I've been lecturing about this for a couple of years, I was always given this. There is no outcomes data, despite all of the science suggesting it was going to work. Well, we have outcome data. Published earlier this year, I was in New Orleans with Rani for the presentation, and the front row for the Clear Outcomes trial presented by Steve Nissen. And ostensibly, this was a trial mandated by the FDA in America of bempedoic acid versus placebo. So no ezetimibe, no PCSK9, and these were patients who were statin intolerant. And clearly you've got the data there that we've already mentioned about bempedoic acid. But to get into this, you had to have what they defined, the FDA, as true statin intolerance. Intolerance to two or more statins or one statin if unwilling to attempt a second statin or advised by the physician not to attempt a second statin. But very low dose statin was approved, and it was blinded. To get in, you had to have an LDL above 2.6, and it was endpoint driven. Now, these are the statements that patients had to sign. I can't tolerate these medications called statins, even though I know they would reduce my risk of a heart attack or stroke or death. And then the provider, the physician said, in my opinion, this patient is unable to tolerate statins. So this was the hierarchical endpoints. This is a statistical technique. You have to meet point 1 to get to point 2. We'll go through that in a second. But you can see that the traditional endpoint of 3-point MACE, that's heart attack, stroke, or cardiovascular death, was the primary endpoint. So the study milestones. This study was done during the pandemic. People were enrolled up to August 2019. The average follow-up was 40 months. So you can see that many of the patients were taking this during the pandemic. And it's remarkable to the investigators that the trial was finished. This is the baseline data. This is an unusual trial, but a great trial because you can see half of the patients were female. The baseline LDL was 3.6. You can see that, and this was deliberate, 30% were high-risk primary prevention, more of that later. 70% were secondary prevention, previous cardiovascular events, and about 45% had diabetes. You can see about a quarter had baseline statin usage. Now, this is the LDL levels during the trial, and you can see in placebo, the LDL went down quite a lot. And this is because the investigators were allowed to use the other therapies. And I and others were showing things like PCSK9 therapy were working, ezetimibe should be used more. So people were on those, and it diluted the effect of the drugs. But you can see there was about a 21% reduction in LDL. And on the right, and this is quite important as well, there was about a 1/5 reduction in HSCRP. We think inflammation is important in disease. Now, these are the primary and secondary endpoints. 4-point MACE is 3-point MACE plus revascularization. 3-point MACE is heart attack, strokes, cardiovascular death. And you can see that these were highly statistically significant. Interestingly, there's a little bit of a discussion going on at the moment between Inclisiran, the company in America who did the trial, and Daiichi, who market it in the rest of the world, because they were hoping that the 4-point MACE would be 0.85, the 3-point MACE is 0.85. So the question is, which is the right answer? We'll find out what happens with that. But the bottom line is, with a 3-point MACE of 0.85, if you go back to the sorts of calculations I was talking about earlier, using the cholesterol treatment trialist collaboration calculation, this is exactly the result we would have anticipated for an LDL cholesterol reduction of around 20%. So certainly this seems to be in line with all the other trials we've done with ezetimibe, with evolocumab and alirocumab, the PCSK9 monoclonal antibodies, and it's absolutely where we would anticipate the results. Now, fatal and non-fatal infarct were reduced, revascularization was reduced, and of course both of those have cost analyses. Fatal and non-fatal stroke was reduced numerically by 15%, but didn't make it statistical significance. So everything else is nominal. But you can see there about a 1/3 reduction in hospitalization for unstable angina. Now, when you think about the heart failure trials, that's really important because it's the commonest reason to come to hospital in the UK is chest pain. So if we can reduce that by a 1/3, think of the beds we could save with this therapy. Now, interestingly, in the study, and we'll debate it, cardiovascular death and all-cause mortality overall were not reduced. And that's generally because patients, particularly with secondary prevention, are on all the other medications to reduce their mortality. If we look at adverse events, there were very few adverse events. Diabetes, and this has just been emphasized in a paper in the last week, there was less diabetes in the bempedoic acid group rather than the placebo. You'll remember statins increase diabetes, particularly rosuvastatin over atorvastatin from the recent Lodestar study. You will see, though, that we think from an off-target effect on the kidney on a protein called OAT3, there was more gout and there were more gallstones. Again, a paper published in the last month, no more cholecystitis, just more gallstones, which is interesting in itself. And it may be how the liver is dealing with cholesterol being part of gallstones. But if you look at the forest plot, there wasn't really a group that didn't benefit from this therapy. It looks like it works on all of the groups. And I think importantly, you have to realize that this trial mandated by the FDA allowed the physicians to use other therapies. And of course, much more therapy was used in the placebo group. So you can see more statins, more PCSK9 monoclonal antibodies, more ezetimibe was used, which diluted the overall effect that we're seeing. And probably the effect, if we were truly against placebo, would be much larger. Now, if you look at the lipid-lowering therapies, you can see over the study, more and more patients, particularly in placebo, were on additional therapies. And this was part of the protocol, but the protocol was specified by the FDA. So this trial enrolled only patients with documented statin intolerance. Other therapies were allowed, which narrowed the LDL differences, and it was problematic with the pandemic. But I think this was a phenomenal trial, and it does show us that we now have absolutely an alternative to the patients that won't take statin therapy. So it's well tolerated. It lowers LDL by just over 20%, and it lowers HSCRP. And as you can see, the main endpoints were reduced. So that was published in the New England Journal. Literally within a few weeks after, the 30% of patients who were primary prevention were also published. Now, these were not just any old primary prevention patients. They were higher risk patients. So they had a score risk that's equivalent to our QRIS-3 of 7.5% or more over 10 years. They had diabetes and were older, or you can see there they had a calcium score of over 400. Now, new data for calcium scoring. Calcium scoring is easy to do. It's in the American Lipid Guidance. And I think the important things is these are patients that have not had heart attacks, strokes. They go on the CT scanner. And if you have a calcium score of 300 or more, and this has just been published by my friend Matthew Budoff, your event rate is the same as someone with established cardiovascular disease. So we should assume that these were higher risk individuals. And of course, because they're not deemed to be secondary prevention, they don't get all the other therapies we give. They also don't think they've got heart disease and come into hospitals. So inevitably, this population has a higher risk. And when you look at the endpoints for the study, their benefits were much larger, a 30% reduction in 4-point MACE, a 1/3 reduction in strokes, heart attacks, or cardiovascular death. And when you follow this through, MI was reduced, stroke was reduced again, but not statistically significant. And because of that, there was a nominal reduction in cardiovascular death and an all-cause mortality of 27%. So certainly, this does seem to be an option in primary prevention. Again, with the same limitations, and remember, this was a secondary analysis of the main study. But the overall conclusion was that this seems to work incredibly well with no major adverse events. An adverse events paper has recently been published emphasizing that the overall benefits of this are larger than the deficits. So we're now getting more information. One of the interesting things is that Paul Ridker, the king of inflammation, has published using this database baseline HSCRPs. And one of the important things is that HSCRP is an even bigger predictor of mortality. That doesn't mean that lowering LDL cholesterol doesn't work. It means that we need to find inhibitors of HSCRP. We've used in a study called CANTOS, an interleukin antibody. We've used colchicine in the COLCOT study. We're doing a study at the moment called ZEUS with an antibody against interleukin 6, and hopefully that will give us new therapies for treatment. Now, but the bottom line is we've got in 4S with teripedicine from 4.9 to 3.2. The Fourrier trial I'm going to talk about in a second, we went from 2.4 to 0.8. Where do we sit with clear outcomes? These are in higher risk patients. These are in the classic patients who have heart disease and stroke and who are high risk, have, for instance, a high calcium score, but can't take statins. Give them bempedoic acid, ideally with ezetimibe, and you get around a 38% reduction. I think 400 patients on it now, and I'm doing really well without any major adverse events. So this is the European guidance. You can see really we're targeting for those patients in Europe 1.4. That's much lower than 1.8. How are we going to get there? Well, the reason we're going to get there is PCSK9 targeted therapy. So let's just jump across now to PCSK9 targeted therapy, because I think that's really important.
Just I've got a couple of questions. Sorry,
Sure, yeah,
Dan.
perfect timing. Go ahead, Rani.
So one thing that comes back is while the approach you suggested in the European Heart Journal article is very much what we sold on in terms of the lower the better and the
Yeah.
probably the quicker. But how do you reconcile that with the nice TAs,
Oh,
which
I said
restricts
this
the
in Parliament
use?
last night. Yeah, nice is wrong. Sorry, but nice is wrong. One of the problems we've got is, particularly with PCSK9 targeted therapy, that the cost was really very high. So NICE came out with this figure of 3.5. I'm about to show you the data from Fourrier and the Inclisiran studies. And in Fourrier, to get in, you had to have an LDL above 1.8. The average LDL for entry was 2.4. 2.4. And we took the LDL down by more than 50%. 2/3 of the patients had an LDL below 1. The average LDL was 0.8, and we showed benefit. And that's why the North American guidance, the European guidance says you want a really low LDL. So I hate to say it, but I think NICE is wrong. And I said this to the Health Select Committee last night. Because we need to get the LDLs lower. And I think if we give people false figures, it will be a mess. And I think one of the problems we've got is with that mixed messages is that NICE have picked figures from nowhere. And I know you and I have discussed this. If it were me and I'd have heart disease, I want to be where the science is, which is exactly where we're at. So, I mean, I think that's a great question. And it's something that I spend my life, I think fighting is the right answer, because I think for patients, we want the LDL lower.
Of course, just using the other hat on from pharmacy perspective is that when formularies and pathways are restricting our use, of course, in exceptional circumstances, as specialists, we might push it that way.
Yeah.
But I think for the general approach that we'd use according to the local pathways would be yeah, the 3.5. So it's going to be challenging for us to implement it, but probably I can see your scientific argument for it and probably a specialist push for it. Another question for you.
Sure.
Bempedoic acid. So the NICE TA is clear about the indication that number one, it needs to be used with ezetimibe. And number two, it needs to be restricted for use for patients who either statins contraindicated or not tolerated. So just a bit of elaboration about the use of bempedoic acid monotherapy and also its use with high intensity statins, given that NICE doesn't cover that as well.
Yeah. Yeah. Okay. So the first thing to say is I'd like you to use it with ezetimibe. And I'm very clear about that. Whether you want to give ezetimibe first, wait for 2 months, realize from the mathematics you're not going to get there or not. Remember, the ezetimibe comes free with the bempedoic acid as well. So it's a single pricing. As far as the add-on therapy, both of these block synthesis. So you don't get a 20% reduction in LDL if you add bempedoic acid to full dose atorvastatin. You get about a 10% in the limited studies we have. There's some unpublished data. And it's somewhere in between 10 and 80, you get a variation. But you and I know, and I introduced the 5 milligram dose of rosuvastatin, you and I know that lots of people won't get above 5 milligrams of Rasuva, 10 milligrams of atorvastatin. And for those ones, this is an ideal scenario, A, for ezetimibe, but B, if they're not going to achieve target, and B, for the combination tablet. So interestingly, there are lots of combination tablets of atorvastatin and ezetimibe around the world. I think we're the only jurisdiction where they seem to have not taken off. I think that would be an obvious thing to do. But that's a situation where if I give someone, if they're on 10 of Etorva, I won't take 20, doctor. We can debate whether that's real or not. Then bempedoic acid will, with ezetimibe, give you another 30% reduction in LDL cholesterol, which will get you to 50 to 55%, quick mathematics, reduction in LDL cholesterol. So they're like Lego bricks to build that wall to stop the flood.
And people asking if there is anything in the Birmingham area with a pathway different to what we have nationally.
So what I tell people everywhere, and I've got them to adopt it in the Black Country, is you go to that really nice document produced by Dermot and Rani, my friends, NHS England Lipid Guidance. You download that, and then you say, that's what we take on. So you were allowed to do the way you guys have done it. I think is phenomenal. I said it to Dermot last week in Scotland, and I'm saying it to you. I think it's a phenomenal document, and this is evidence based. To be fair, you have to abide by the NICE rules. So everything there is nice. Some of the things I'm saying to you, simply NICE haven't said anything about. So I think it's important we discuss it. But that gives a framework. If we just did what's in the NICE document, we'd have many, many more patients at target.
Thank you. There's a question about CAC scoring.
Yeah.
Is CAC scoring done routinely in patients with elevated LDL?
No,
And are we looking at the end of niacin use? That's two questions in one.
Yeah, okay. Well, niacin basically gone. I've not used niacin for. I mean, I did the trials with niacin, and the flushing was awful. So no, I'm afraid that's gone. I think fibrates, other than stopping people getting pancreatitis, have gone. And we've got these drugs that work. Why wouldn't we use the drugs that work? We can debate how Vascepa works. Happy to do that. I think it's probably LDL cholesterol reduction, but we don't know yet. But suffice to say, I wouldn't use niacin, and I probably these days I'm not using fibrates except for hypertriglyceridemia to stop pancreatitis.
Thank you so much. I'll hand over back to you to resume. If there are any questions, I'll keep them.
Super. Let's talk about PCSK9 targeted therapy. So let's go to that talk. Tell me when you can see it, Rani. Okay,
Yeah,
so
it's come through.
fantastic. So this year, it's 20 years since Professor Boileau wrote the original paper in Nature Genetics describing PCSK9. And you all know that cardiovascular disease is our big killer. I think this is an important slide. So if you think about what people die of, if you die, and the number one cause for women in the UK is vascular dementia. If you die in your 90s of vascular dementia, that is success. I would argue that if 50% of it we think is atherosclerotic, and therefore we can't do the trial, but our assumption from all the modeling is that if we lower LDL cholesterol, we'll reduce the amount of vascular dementia. But what I see every week is someone in their 20s and lots of people in their 30s coming in with acute myocardial infarction to Birmingham City Hospital. And if you die in your 20s or your 30s of an infarct, you'll lose lots of life, years of life. And the biggest killer worldwide when it comes to years of life lost is cardiovascular disease. And of course, the biggest killer is atherosclerosis. I've shown you this graph already. We've got the randomized trials, we've got the cohort studies, we've got the Mendelian analysis, and NHS England now recognize it. You know, we were at a meeting about a year ago when they admitted now that they thought that we cured cardiovascular disease, and they took it out of all their agenda. Well, they've put it back in now. It's number one in their agenda because they think that we can massively reduce cardiovascular events, particularly related to cholesterol. 7.1% of deaths in the UK are related to cholesterol. And the therapies work, and most of them are incredibly cheap. So there is clear evidence that lowering LDL cholesterol, for every millimole reduction in LDL, you deliver a 22% reduction in 3-point MACE per year. And we know that having a low LDL is normal. If you look at the right first, if you look at primitive societies, farmers, if you look at other animals, LDL's total cholesterol is below 3 are normal, and LDL's much lower are normal. If you look at the left, an LDL of 0.8 is what you have at birth. Nobody's worried about that. And they're worried about it if it's higher in it because you might have familial hyperlipidemia. But an LDL of 0.8 is normal at birth. LDL of 0.8 is exactly where we got on average in the Fourrier study. So you know about this. This is Terry and I. We've covered this already. And we know that in Eurospar, only about a third of patients get to the target of 1.8, not 1.4, but 1.8 with statins alone. We know from a study before Santorini Da Vinci study that the only way you get to target is to give combinations of therapy. And we know about statin intolerance. We know that this is a really important paper. This is from Sweetheart in Sweden. If you've had bypass surgery and you go to your pharmacy and pick up your tablets versus you don't pick up your tablets, that's all recorded. And if you've had bypass surgery and you don't pick up your statins, you're twice as likely to die. Now, interestingly, beta blockers don't have a major effect. ACE inhibitors, angiotensin receptor blockers, and blood thinning agents do. But the biggest effect of all is with lipid-lowering therapy. And most of our research has been on statins, but as we said, we're doing all these trials now and all these other therapies. So how was PCSK9 discovered? 97% of people with familial hyperlipidemia, so cholesterol's 10, sometimes 20, will have abnormalities of the LDL receptor. They get one from their dad, one from their mum. And if both of them are abnormal, their LDL receptors don't work, then they have a cholesterol 20. Why is that? The LDL receptor, and Goldstein and Brown won the Nobel Prize for this in 1985, it's a dumper truck. It grabs LDL from the circulation, takes it through the liver, chucks it out into the biliary tree, into the gut, and then goes back to the surface. It does that about 100 times. And as I say, 97% of people with familial hyperlipidemia will have an abnormality of the LDL receptor or its associated proteins. But about 3%, nobody knew what the problem was. And Boileau discovered this protein called PCSK9, which binds to the LDL receptor, such that when the LDL receptor is internalized, bound to LDL, instead of just getting rid of the rubbish, the LDL, the liver gets rid of the dumper truck as well. So more PCSK9, fewer LDL receptors, higher cholesterol. And we know that PCSK9 varies around the world. We know there are individuals with no PCSK9 and they're normal. And so this seemed like an ideal candidate for therapy. So with a company called Amgen, we developed an antibody called evolocumab, which bound to PCSK9 and lowers your LDL by around 50%. In a study in an intravascular ultrasound looking at plaques with a camera, my friend Steve Nichols in Australia showed that the plaques become more stable, that the tipping point is below 2 and certainly 1.8. But the lower you took the LDL, the more the plaque would reduce in volume, the more it would become stable. So we took this into a very large trial called Fourrier, 27,500 people globally. I was the UK chief investigator for this, and we gave people placebo or evolocumab. To get in, your LDL had to be above 1.8. So also that most of them were on high potency statins, as you can see, and so the average LDL to get into the trial ended up at 2.4. Think about that. This is a drug that lowers your LDL by another 50% and more. And we were starting at 2.4. Think about where the guidance is at the moment with NICE. You can see here overall there was a 59% reduction in LDL with no diminution effect, a 20% reduction in 3-point endpoint of cardiovascular death, MI, and stroke on top of statin therapy. And the achieved LDL on the left here, 2/3 of the patients below 1, average LDL 0.8. And the other thing, people assume it reduces your first event, and it does, but it's even more likely to reduce your second event, even more likely to reduce your third or fourth event, because as the cholesterol is coming out of the artery, the plaque is getting more and more stable. That takes months and months. You're much less likely to have a heart attack or a stroke. We saw no major safety issues. The only safety issue we saw was some erythema around the injection site. And of course, everybody saw that with the vaccines as well. And there was no bottom to the LDL. We had lots of patients below 0.5. We had many patients below 0.25 with no reduction in brain power or any other things, but a big reduction in cardiovascular events. We did the brain power study. Again, I was UKCI for this. This is Ebbinghaus and done with Cambridge, all around the world. We assessed brain power. There was no significant differences between the groups. So it doesn't lower your brain function. People said it would cause hemorrhagic stroke. It didn't. Bob Giuliano, my friend at Harvard, showed this. What it does do is it massively reduces ischemic stroke, having a very low LDL cholesterol. So you've seen this already. The American Heart Association say LDL lowering therapy does not appear to lead to cognitive impairment or stroke. And they've also said there is no bottom. Now, with this study, not in the UK, but in other countries, people went into an open label extension. So even the patients on placebo got open label therapy. And you can see here going out to nearly 8 years, we have data that it took another 2.5 years for the curves to become parallel. So that benefit, there was a legacy effect of having the first 2.5 years on active therapy, but then there is no catch up. So having a very low cholesterol for that first 2.5 years of the trial gives you a long-term effect. By the way, that was shown in the West of Scotland coronary prevention study with pravastatin many years ago. And there is that additional 20% reduction that it continues. So there's no doubt whatsoever that resetting the clot, getting the plaques more stable, resets everything back. And there was no major adverse events. These were patients who had already been on placebo or active, but you can see on the long-term extension, there were no major adverse events, which is good, and no hemorrhagic stroke, and there was no diminution of effect. So there's no doubt whatsoever that evolocumab is a useful therapy long-term. It's important for class 1A evidence. You have different research, different drug, different investigators doing the same sort of thing. The Odyssey study, Kosh was involved in this, was alirocumab versus placebo. Again, a very well-run trial, 9,500 in each limb. And again, a big reduction in 3-point MACE there, a 15% reduction and a 15% reduction in all-cause mortality. Interestingly, the higher your starting LDL, the more likely you would be to get a mortality benefit, and that makes sense as well. Again, we've got a long-term study now of the Odyssey outcomes, so there's no diminution effect, but ongoing benefit. So that suggests this is a good long-term therapy. So we've got both monoclonal antibodies. We've got, I'm going to talk about in a second, Inclisiran, and we've also got other therapies coming. Just to mention to you, and I'm just going to rush through this, that there is an oral PCSK9 inhibitor coming. Merck have this. It's probably going to be available in about 4 years. It's a once daily tablet, and it works. They examined 10 to the 10 compounds to 10 to the 14 compounds to find this, but it undoubtedly works. And so that is coming. And I'll just mention as well that there is another antibody coming that lasts 3 months from China. And the South Africans have a different compound here, which also binds to the receptor. So PCSK9 targeted therapy is here to stay. I think a lot of these will come to market, which is important. Okay, so, but there's still this big gap. This is our Santorini study. I've already mentioned this earlier on. It was a European study, and ostensibly what we showed was that around Europe, the only people that are attaining and achieving the levels are patients who have combination therapies, particularly given Inclisiran. So I'm going to switch now, Rani, to a different presentation about Inclisiran. Is there any questions whilst I'm waiting? He's gone off for a cup of tea.
Nothing. Sorry, no, I'm here. Nothing have come through.
Okay, right.
So
let's just
is you in your locality? Do you have PCSK9 monoclonals used?
Yeah.
In primary care or secondary care? Because most of the country use it in secondary care, initiation, that is, and maintenance. But I know some areas use it in primary care.
Yeah, to be honest, it's nominally only a secondary care drug. That was defined by NICE. They were worried about the cost. But what we're seeing now is that PCSK9 targeted therapy is mature. It works, and I think we should have all the things in the armamentarium. And so I'm going to introduce Inclisiran, which there are now 200,000 doses of Inclisiran out with clinical trials worldwide. Kosh and I have spent a lot of time traveling the world explaining it to people, as you know. So let's just run through this. Small interfering RNAs are here to stay, and Inclisiran's the first big use one, but pretty much every day there's a paper in the medical journals of a new one. Now, this is a really clever technique. My PhD was in molecular biology in Cambridge. I thought this was going to happen 25, 30 years ago. It's now happening, and pretty much the FDA and the EMEA are giving small interfering RNAs ticks for usage every day. So you're going to see this in every aspect of medicine. How do they work? Well, we all know that DNA is transcribed to mRNA, is translated into proteins. And of course, with antibodies, that's how we block proteins. But why don't we go one stage earlier and stop the protein being synthesized? And you can use the body's own system, and that's where Andy Farr and Craig Mello discovered it. You can use the body's own system called RISC to switch off any protein you want. And, you know, this is going to be phenomenal in sickle cell disease. It's going to be phenomenal in amyloid, in rheumatology, in cancer. These drugs are here to stay. This is the first big one. We're not seeing any major adverse events, by the way, other than the injection side reactions for these, which is great news. There, when you think about the safety data, for instance, for statins, from what we can see, these are much safer. In fact, the European Medicines Agency, so you say you don't have to check the liver function tests, the blood count, etc. with this.
So Derek, sorry to interrupt your flow.
Sure.
Just a question that usually comes up frequently is, For Inclisiran and for the PCSK9 inhibitors, there is a threshold for initiation. I know we're not necessarily in full agreement with NICE on these thresholds, but they dictate on us these thresholds.
Sure.
In terms of planning introduction these therapies so that we don't miss out on them. So usually people go for statins, then think about maybe ezetimibe. What's your advice or practice with regards to not missing on the
Yeah.
opportunity of ensuring that patients do
Okay.
are offered these medicines if needed?
Okay. So Rani, you've hit the nail on the head, and this is a very intelligent audience. And everything I do is for the patients, and I game for the patients. So as long as I'm within the laws of the game, I will do everything to win the game. So if I can calculate the LDL, and we've argued for a long time that everybody should have a calculated LDL, for someone coming with an ACS, I will calculate the LDL based on the admission bloods. And if it's quite clear to me that atorvastatin and ezetimibe are not going to get your LDL anywhere near where I want it to be, then I don't give them ezetimibe. I give them atorvastatin. And either, in some of the cases, it's so high that I give Inclisiran as an inpatient, or when we bring them back to rehab and we do that at 4 to 6 weeks, we don't wait 3 months for bloods. We recheck the bloods, and if they clearly make Inclisiran, they get it then. But the Odyssey study suggested the earlier you give it, the better. So to some extent, I would like to give it for those patients that clearly will merit it as an inpatient. There is an argument to give it in the cath lab because it's a single injection and it lasts 6 months. In fact, it lasts a year. So why wouldn't you do that? And those studies are happening. But yeah, I think as long as within the laws of NICE, I'm happy to game for the patient. For the vast majority of patients, we give them Etorva 80 and 10 of ezetimibe. We recheck their bloods at rehab, and we're still finding it somewhere around 1 in 10 will merit Inclisiran. It might actually be higher than that, but 1 in 10. And of course, when we recheck the bloods, it becomes an option as well. Now, this is the Orion development program. It is ongoing. Orion 4 and Orion 2 are still in the follow-up phase and recruiting phase for Orion 2 prevent, but the rest of them are pretty much published now. Inclisiran, monoclonal antibodies lower your PCSK9 for about a month. Inclisiran does it for a year. So if we look here with a single injection, you can see it going all the way down.
You're not sharing your slides, Derek, sorry.
All right, so let me do that just now. My phone's going as well. Let me just... Can you see yourself?
Yes.
Okay, so let's just run through then, so you've seen them there for the audience. So there's Andy Farr and Craig Mello, the inventors of this technique. They won the Nobel Prize, as you can see. And it blocks PCSK9 protein before it's produced, whereas the antibodies block it once it's produced. This is the development program, and most of these are published. Victorian and 2P and Orion 4 are still to publish. But this is the dose curves, and you can see there that ostensibly with a single dose, you get about a 50% reduction in LDL. Not as much as the antibodies, because it only works on the liver. Within 48 hours, by the way, it's out of the body. That's true of all the small interfering RNAs. It's all concentrated in the liver. But look, even at a year, you're getting a 20% reduction in LDL, which is roughly equivalent to bempedoic acid with a single injection. We give it at 0 months, 3 months, and then every 6 months. And that's because of the pharmacokinetics of the drug. But as I say, a single injection, even at a year, gives you 20% reduction. Now,
sorry if I may interrupt you there, Derek,
sure.
again, because a question that we often get in terms of after you initiated Inclisiran, when should you check full lipid profile? Should you wait for 6 months? Should you do it after 3 months?
So
What
do
you recommend?
Yeah, I'll tell you what I do, which is I check the bloods when the patient comes up for the second injection. Now, I'll be honest, although it's not mandated to check the liver function and everything else, I do. But I check the lipids and I write to the patient. And I write to the patient to say what their LDL is, because that is a motivator going forward. Now, given the fact that it's part of QOF, it only needs to be annual after that, and you don't need any other check bloods. So I do it at baseline, 3 months, and then yearly, theoretically. In practice, most of the patients end up with more bloods than that, as you know, but that's what we're doing at the moment. Okay, let's go to some of the trials that have
Another
been
question,
published.
sorry,
Sure.
Derek. Another question from the audience is that if the 3 months mark window has passed, when do we consider restarting the cycle from 0 months?
Okay, so this has been made up, but in practice, it's quite nice to have rules. So if someone misses a window by more than 3 months, you go back to the loading dose of 0 and 3 months. So ideally, you give them 0, you give them 3. If they then go to beyond 9 months after that, you should give them a 0 and 3 again. That is the rules. But the truth is, that's modeling rules. There are no studies. So in practice, this is a great drug. A lot of my patients go to the Punjab for the winter, and monoclonal antibodies were ridiculous because they couldn't take them on the plane and they couldn't refrigerate them in the Punjab. And this is great. They come and get their injection before they go off and they come back and get their next injection at 6 months. And we've got quite a few now who are like that. So that they think it's fantastic. And there are no syringes to take. So I have lots of patients who've historically been on the monoclonal antibodies who are now, at their request, on Inclisiran, who are doing really well. Now, their LDL looks very similar. Theoretically, you get an extra 6 to 10% reduction with the monoclonal antibodies. But in practice, because the patients are, this is healthcare professional given, are taking the therapies, I think overall their LDLs will be better. Okay, Rani, let's go through Orion 9, 10, 11. Orion 9 was in heterozygous FH. Orion 10, it was in United States in atherosclerosis. Orion 11 was in Europe and South Africa in mostly atherosclerosis with some high risk individuals. Slightly different trials, but the injections were given 0, 3, and every 6 months. These are the baseline status. You can see the average ages, older patients, the average LDL, particularly in the FH group, was 4. In the Orion 10, 11 was 2.73. So not that different with the Orion 10, 11 to where we were in Fourrier. Most of the patients were on high potency statins. All of the trials used this 0, 3, and every 6 months. And ostensibly, you get a 50% reduction in LDL cholesterol. Now, if you look at it, if you are looking at the GP contract at 1.8, using the Orion 9, 10, 11 pool data, you're going to get nearly 90% of patients to the QOF target of 1.8 or below. So that is really remarkable. And of course, that's because it lowers your LDL by 50%, not the 20% with bempedoic acid or the 20% with ezetimibe, but by 50%. Interestingly, virtually no side effects, as you can see from this. This is why the EMA and the FDA say there are no monitoring of bloods necessary. Now, we have to wait on the big powered outcome trials to say definitively what the outcome will be. But I've already explained several times that we know how low the LDL is going and we know how long the patients will be on it, so we can predict the cardiovascular event rate reduction. Now, Kosh has done this with the meta-analysis of 9, 10, and 11. Take it with a pinch of salt, but I've put it in yellow, and you can see that there is a 25% reduction in 3-point MACE. That is exactly where we're anticipating the large outcome trials to be. So I think we are getting evidence that this is safer, and it seems to be working from the trials. And hot off the press from the ESC in August, you can see there Orion 8, which is an open label long extension out to 7 years now, that 78% of the patients are achieving their LDL goals of 1.8 in Orion 8. So this is long-term data showing that this works. Special
Sorry,
doses.
Derek, we've got only 3 minutes left, and just
Okay,
wanted to
let me
give a
just go to.
chance.
So
I've
this is
got one more
Kosh's
question
data.
for you. I want
Sure, go ahead.
one more question. Somebody's asking it was noticed that few patients' triglycerides have increased slightly on Inclisiran. Is that
Yeah.
something that you come across at all or
No,
reported?
to be honest, I think what happens, I've seen this as well. I think what happens is when people know their LDL is really good, their diet changes a little bit.
Right.
And I think that's what's happening.
Okay.
Remember as well, if you really want to measure triglycerides, do a fasting sample. So I've a few of them where it's gone up a bit. I've done a fasting sample. In the fasting sample, if the triglycerides are still above 1.7, refer to a brilliant guidance by Rani, Khatib, and Dermot Neely that suggests that Vascepa is useful. because that's a really good drug as well. Rani, just to finish, you asked me some for case studies. I just want to show you one case. Okay.
Okay.
This is the classic person who you should be giving this to, Inclisiran. This is a 44-year-old HGV lorry driver, no real risk factors, strong family history of coronary disease. He's coming with a total cholesterol of 7.8. His HDL is 0.8, so his non-HDL is 7. His calculated LDL is 6.4. He has primary angioplasty, he has good left ventricular function afterwards. You've seen this paper already. We give him atorvastatin and ezetimibe. He comes back. His total cholesterol is still 3.9. His LDL is 2.7. This is absolutely classic. My nurses will just give the Inclisiran, and it's now gone to 1.4. So that is an absolutely real case. Just one quick other one. This is a Lebanese physician. She's a colleague's wife. Her mum had FH and had a heart attack at 44, wasn't diagnosed as FH. So I said, we need to check your cholesterol. We did. Her LDL was 7.7. This is a CT coronary angiogram with a technique called heart flow, which I introduced into the UK. You can see she's got a lesion, but she's asymptomatic. We treated her with medications. She's got an LDL receptor abnormality. She was on atorvastatin, ezetimibe, and evolocumab. She then wanted to have babies. We stopped everything. We did stress echoes. Everything was fine. She had a baby boy. And I said, let's go back on the therapy. She said, no, I'm having another one. She had a baby girl. Her choice, she's now on Inclisiran, atorvastatin, and ezetimibe. Her stress echo remains normal, and her LDL is 1.6. And I think there's a very good chance that she won't have a heart attack in her 40s like her mother did. So real examples of real cases, Rani. And we're using, the secret here is to use your whole armamentarium.
I've got one question about, was there a reduction in overall mortality in Fourrier trial? I've heard there wasn't.
Yeah.
Is this correct? If so, any obvious explanation for this,
Sure.
given the lack of reported side effects?
Yes. So it's the population you use and what you're doing. So if you look at the study population from 4S 30 years ago, there was no primary angioplasty. You know, they call me the professor of polypharmacy. If someone goes home with a heart attack and they're diabetic and they're hypertensive, Connolly has them on 14 medications, all of which we know lower mortality. So you wouldn't expect a mortality benefit. The other thing is, once you know you've got coronary disease, if an elephant sits in your chest in the restaurant, it's not indigestion, it's your heart, you go into the hospital, so your behavior changes. So it's incredibly difficult these days, because of all these factors, to show a mortality benefit in a relatively short drug trial, such as Fourrier. But in Fourrier open label extension, out to 8 years, we did show a reduction in cardiovascular mortality. So that's good news. It's because the event rate is so much lower that you can't see that. And the trials, to power a trial for mortality now with cholesterol, you would have to have 200,000 people. Now, Fourrier costs £6 billion, I think it was. So you're not going to get that. You're not going to get a trial that is powered for mortality for cholesterol. But of course, strokes and heart attacks are incredibly important. I would point out that there's no rise in mortality, but a big reduction in strokes and heart attacks. So yeah, that's why the trials are powered there. That's why we're not seeing mortality benefits.
Thanks, Derek. So if I want to summarize what we've learned from you today, and please add any additional comments. Bempedoic acid best given with ezetimibe to get more reduction. It's mainly indicated in patients who are either contraindicated to be on statin or intolerant, and potentially might be outside nice, but it doesn't matter if somebody can't tolerate really decent doses of statins. Otherwise, we're not expecting more than probably up to about 10% reduction additional, which we don't usually recommend with high intensity statins. It's a straightforward, there is some evidence for it, and maybe watch for if somebody's got any uric acid increase, stroke, gout concern. Anything else you would like to add in a summary about this?
Yeah, I think, remember, 1 in 5 people in the UK, and that's been confirmed on CVD Prevent, are on nothing. Now, I'm not a salesman for Daiichi or Aspirian, but isn't it logical to give them bempedoic acid and ezetimibe? They should be on something and they're on nothing. And it does look like it's got outcome data. So that one's a no-brainer. And I think PCSK9 targeted therapy, Rani, is now mainstream. And we need to be using Inclisiran. NHS England have written to all the leaders in NHS in England and said, please use this. We want you to use it based on the study evidence.
And the PCSK9 therapies seem to be highly efficacious in terms of giving really decent amount of LDL reduction, talking about 50% and more. And the good news that we've got good evidence for the monoclonal antibodies, of course, and coming more cardiovascular outcome evidence for Inclisiran in the pathway, but safety seems to be there, and we're kind of reassured. Yes, there are thresholds for initiating this therapy. Therefore, maybe think about where you're going when you're initiating lipid lowering therapy in order to not patient miss out on these therapies. And there isn't any magical kind of more extensive monitoring that is needed. To the contrary, it's actually less probably things to worry about compared to LFTs and all this that we need to worry about. Any other tips?
Yeah, well, just think about it. One of the things I'm trying to press the government and the manufacturer, think about how many people are taking Ozempic now. It's exactly the same as giving Ozempic. It's exactly the same, and people are giving themselves it all over the world. Okay, this is once every 6 months, and if a healthcare professional gives it, it's in.
Yeah, fantastic. Thank you so much for your time. Thank you. Everybody seems to be asked all the questions. Can't think anything else there. Please, everybody, if you can complete the feedback form, we will send a recording, of course, of this session to you. I would like to thank my colleague Derek Connolly for giving us his time. Much, much appreciated. Thank you for coming to our series and supporting us. Thank you very much, Derek. Thank you, everybody, for attending. All the best. Thank you.